I was commenting just now that up here we were disciplined in sticking to 5 minutes, so I was expecting the same from all of you in your conversations, but only really so this was sort of a message that it's time to stop talking so we can start talking in the larger group. So we had our conversation around this kind of virtual table, I suppose, and a theme that came out, which is a real challenge to sustainability, is the territorial imperative. And in fact, when you look at the Indian Act, the Indian Act actually sets up every band, every First Nation is in competition with every other First Nation. And when you look at Canadian Medicare, it's a way of paying for individual health care providers, small businesses. Historically, medical practitioners are small business providers, and so health services, whether we're talking about nurse practitioner clinics and the family health team as an example here, they're in competition with each other. So that's certainly a challenge to sustainability. I'm keen now to hear from you as to what particular comments you have, challenges to sustainability, maybe questions that you have of the panel, and if you keep your questions and comments clear and succinct, then we'll be able to get around all the tables at least once and have input from the participants in the web streaming. So we have a roving microphone to go around the tables, and I'm going to see which table wants to break the ice. Who'd like to speak first? Oh, looks like we've got a taker over here. What we might do is have comments from several tables and then an opportunity for the panel to say something, and we'll go backwards and forwards like that. Go ahead.
Hi, I'm Rebecca Rich. I'm a OBGYN here in Toronto, but I've done lots of work in the north, and I trained here. So what I had sort of brought to the discussion was about training of physicians. And you guys at NOSM have such a unique sort of mandate, and I think that as a trainee who grew up near Toronto and trained in Toronto, I wonder a little bit about the role of other institutions that don't have the same mandate as NOSM to be able to train both physicians and other providers for rural and remote areas. Because I think when I was training, there was no mentorship or way to be able to know what that kind of practice was like. So I think you guys have a really unique and special role. And we are also sort of discussing about other human resource training programs and what else exists in Canada to train people to work in rural and remote areas, not just as healthcare providers, but at a more systems level.
Great, thank you. So certainly a contributor to sustainability is the supply of a health workforce who are fit for purpose, that is, ready to provide care where it's needed in the communities that need the service. So which table would like to go next? Here we are, this table here. Just speak and it'll, yeah.
So there was a lot of interesting discussions that was had over there and by the panel here, and we only picked one. It's similar to the one that you were talking about there. It's about providing incentives to retain healthcare workers in these communities. So there are really three things we were heading around. Obviously haven't thought it through in the 5 minutes, but they might sound very naive, right? So one is that before we go there, I think this model of NOSM is actually very innovative, and it's very exciting to hear about it. And I think in BC, I'm from BC, by the way, I should have introduced myself. I'm Falgun Joshi from the Rick Hansen Institute, and our focus is on people with spinal cord injuries across Canada. And our interest is, the urban areas are doing very well with people with spinal cord injuries, but the rural areas, there is a problem. So anyway, yes, we recognize that the NOSM model is a very good one. So in terms of retention, one thing that was suggested was that, the healthcare providers are all trained with publicly funded, they're all publicly funded, they're subsidized, that perhaps there could be a requirement for these individuals to go and spend some time in these rural communities, right? Which is not asking too much. You know, many other countries do that. Second is that, the new immigrants who come here, perhaps maybe in their evaluation, if they are healthcare providers, to maybe give them a leg up to come to Canada if they are willing to move to into these rural communities. I don't know if that's being done, but anecdotally, I know that there are some communities where you go and the doctors are from South Africa or from India or from any of these other countries, British Commonwealth countries, whose education, of the physicians is similar to what we have in Canada. The third one is that, people in Toronto, if you're a physician in Toronto or an allied care worker in Toronto or in Vancouver, it's really expensive to be able to afford a house or a condo, right? So you provide financial incentives for the trained physicians to go and work there in the rural communities. They can go back if they want, but the incentive is that they're going to make probably more money than they would in the urban areas, and this is a way for them to come back and have their families and do what it takes to have a family.
Well, thank you for that. I might just comment on a couple of things that you said as the next table prepares to speak and see if any panel members want to speak as well. But so you talked about mandatory rural service, and we had a speaker earlier from South Africa. I'm not sure if he's still here, but they have mandatory community service in South Africa, which basically usually means rural. And in that country and other countries where they have that, it's a mixed blessing, I'd have to say. The issue being that if then the new graduate in doing their mandatory service has a terrible experience and doesn't feel well prepared for what the work they're doing and doesn't feel well supported when they're there, then it's a very uncomfortable, even terrifying experience, and that actually is counterproductive because they go back to the city and they tell all their friends and colleagues how terrible it was and to avoid it if you possibly can. So then you have people trying to get out of that. There is an example in South Africa under the University of Stellenbosch where they've developed a rural clinical school and actually some of the same sort of model that we have with NOSM. And I happened to be in the northwest province of South Africa a few years ago where they don't have a medical school at the moment, but we were actually talking about having a medical school there. And there happened to be one of the graduates of that new Stellenbosch, it was very new then, Stellenbosch program, was an intern in the hospital in that community, and she came and joined us, and she said that, because she'd had that in-context hands-on experience as a student, she felt well prepared for the work she was doing, and she looked forward to being in the emergency department because that's when the exciting challenges came. She observed that her colleagues, the interns, the graduates from the other schools in South Africa, were very anxious and tried to avoid doing their emergency department shifts. And I think it's the issue about the learning environment, the context. So the comment that was made from the previous table, just having a mandatory service actually at best is a mixed blessing and can be really quite counterproductive. And similarly with the return of service obligation, which is the case for in many cases actually for international medical graduates who come to this province, then again, it's how it's set up and to ensure that those physicians feel that they're well supported and welcomed. And that's where the community comes in. That's where the hospital and health service comes in. That's where the medical community and the wider community of the health workforce, the health team, need to come in and really embrace that individual and make them feel, and their family feel, that they want to be part of this community. Don't know if any others want. Yeah, go ahead.
Just to pick up on that, the theme, the community being involved, and we have examples in North Simcoe, Muskoka, where there are community physician recruitment teams, and they do take ownership of making the physicians feel welcome when they come to the community, critical. Flip back to my northern Manitoba experience, where we did all of the aforementioned in terms of trying to attract and retain. And I think to Dr. Strasser's point, the return of service agreement worked and kept things stable for a period of time. However, you needed to complement that so that you would retain after the return of service agreement, because we still lost a lot of people as a result of it. On the nursing side of things, one of the things that we didn't have a Indigenous nursing training program in northern Manitoba, but we worked really hard with the college and the university and established one, a small one, but it developed and was successful because, again, the issue was going from an Indigenous community to Thompson, which was the normal, but having to go to Winnipeg to train became the barrier. And so by at least establishing one in Thompson, we were able to do it. In my other rural experience in southern Manitoba, we had a shortage of RPNs, and so we had to, we took the bull by the horns. We were able to purchase a program, but we partnered with our communities to be able to come up with the money to buy the program from the college to be able to operate it within our region. And the other benefit was that people didn't have to travel as far. Rural community, farming community, they needed to, mostly women who enrolled in it wanted to be close to home. They didn't want to have to travel too far. And so it really created an environment where they could develop their profession, but be close to home. And again, we trained and graduated and retained all of those individuals in the local communities.
Don.
I'd just like to point out from my Sublin community that yes, we have problems with recruitment and retention of primary care practitioners, but the biggest drain on our system at this point in time is further down the continuum of care, and we have a terrible shortage of PSWs. So despite whatever you guys do to solve the upstream problems, unless we can solve the downstream problems, the entire system will be in flux.
I just wanted to make the point that, as you know, the OMA deals with the province only and has nothing to do with the LHINs. And the LHINs have no way of enforcing any kind of accountability with the docs. So that's just to be clear about that. The one exception where we're starting, you could say, kind of directing people is in the areas, designations of areas of high physician need. So I know my LHIN was completely an area of high physician need. I think the Northwest was almost, and I'm sure many places in North Simcoe, Muskoka, where docs got to enroll in the preferred patient enrollment models automatically in these areas and had to go through either couldn't or had a long process to get in elsewhere. So the province has started to address the maldistribution of physicians. So this is not a LHIN position, but one optic to look at physician location is you just need to graduate and get a license. Then you can automatically practice anywhere you want and do whatever you want and bill the public purse for your billings. Kind of like, it would be strange, like if a school teacher could do that. They could just graduate as a school teacher, get your school teacher license, and then just start teaching kids and billing the province, regardless of whether that's where they needed a school teacher or not. So I don't think anybody denies there's a maldistribution of physicians in the province. And the days of just being autonomous and saying where you're going to practice and how are coming to an end. And probably the mechanism of that will be that the new grads want to practice in teams that are supported, and the ministry can support teams and build teams, and entry to them will be controlled. So I think that's likely what's going to happen, and that's what I'm seeing happening.
Okay, let's move on to another table. I have a couple more tables. Who's next? Which is the next table that wants to join the conversation? Over here? It's on. Keep talking and it'll...
Testing. Okay, so no big advice regarding this. I was just wondering if you could speak more to the innovative technological solutions you were referring to previously. I'm not that familiar with much of the technology, although we were discussing it, and I heard of some basic kind of ways of communicating between distance and practitioners. Maybe you could speak to that a little bit in more detail about the potential innovations that are arising that could help with this systems.
Yeah, absolutely. And I could just provide a little bit more detail on maybe the e-consult services that are happening. So the e-consult through Ontario MD is a program where physicians in any community can connect with specialists in other communities. So where that specialty doesn't exist in a northern community, they can have consultations with specialists, say in Toronto. So telederm and psychiatry were two examples that I gave. Some challenges around that just due to the nature of psychiatry services in southern Ontario or non-northern areas. Sometimes it's a challenge. The advice that physicians are getting isn't necessarily context specific, but in light of just having no access to the services that are needed in the northern areas, that is a potential solution that they're looking at that I think we need to do a little bit more work around as well. Any want to add to that? Yeah? No. I'm happy to.
So we have the OTN studios, so you have to go to a place that has the setup with the camera and the big TV screen, and there's, I don't know, I think there's hundreds of them around both LHINs. So then that gets fed back to a doctor's and also an OTN like studio, so that requires the patients to travel. A new thing that I'm currently involved with MAID, Medical Assistance in Dying, is to provide a second assessor. Many of these patients don't want to travel, and it's painful for them to get out of bed. So we are developing what previous CCAC was already using for wound care, which is encrypted Skype-like app for phones, so they'll be able to go from patient bedside to remote doctor location. I just want to add that there is I've seen this creep that I think is an indicator that's sort of taking advantage of technology that's going in the wrong directions to some degree, which is these telemedicine walk-in clinics. So where doctors are living in Ottawa and Toronto and doing walk-in clinics in our towns and not moving to the area, which is not something that I think is the long-term answer.
So I'd like to pick up on that theme and say a bit more about the technology. I said that the systems that work best in rural and remote communities, the specialist services are supporting those local providers. It is not really helpful to then for the specialty service to leapfrog over the district centre or the regional centres to the big city like Toronto. We're talking about an integrated system model, and so we need each part of the system to be supporting each other in a networking sort of sense. So actually having in the Northern Ontario context, so in the Northwest, then the support coming as much as is possible from the specialists and specialty service providers in Thunder Bay, rather than leaping over to Toronto. But to taking what Paul said about Ontario Telemedicine Network, OTN started as video conferencing, VC connections, and there are these OTN rooms just about everywhere in clinical settings now across Northern Ontario. But they've also developed to the next stage, which they call PCVC. So that's video conferencing through your computer, personal computer, or these days laptop. And my colleague, Dr. David Marsh, who is Associate Dean of Community Engagement and Deputy Dean at NOSM, his specialty is addiction medicine. He came from Vancouver, and he was involved in setting up the addiction services in Vancouver. And before he came to Northern Ontario, he only consulted with patients in the same room. Now, over half his practice, he consults with over PCVC. So that's an example. And in fact, his main community of patients outside of surrounding Sudbury is in northwestern Ontario, in fact. So that's the kind of way in which communication technology capacity is being developed. Having said that, the really remote parts of Northern Ontario, and particularly the remote First Nations, this is all great, but they don't have high-speed broadband internet connectivity. So at this point, these kind of initiatives are just not available to them. Yeah, one more.
Nor would they trust anybody they hadn't met.
Right. Okay. Oh, okay.
Sorry.
Quick.
So are there any other technologies that are being used in very remote areas to transfer information for others to diagnose, or like I know when you think about certain technologies that are used globally, like say in Guatemala perhaps, they're actually using technologies so that midwives can actually check on babies that are, as they're treating people. Do we have that issue here, or is there always an understanding that if a patient has some issue, they're going to have to leave the community to go get some more treatment? Or are there diagnostic tools or other things that are used that are technologically based in remote areas, and then that information's passed on? I don't know enough about the...
Yeah, the short answer is yes.
Yes. Okay.
You want to talk about the point of care
just
testing?
One more example. This was talking with the regional critical care, but we also have the tele-wound care. So there's things where there's actually being iPads used. So still technology challenges around that, but actually bringing the iPad, showing the wound where it can't be managed necessarily just in the community, but connecting with the regional center in Thunder Bay to get that real-time advice to say, here's the wound, is there advice that you can give me so that the patient doesn't necessarily have to be transferred? So it's another example of that.
That's great. Yeah, that's what I was trying to understand, is how deep the technology goes, other than just face-to-face.
And there's increasing use of point of care testing as well, the technology to do tests with, so rather than the patient having to travel to have tests done, to having them done. And particularly that's being developed in the Northwest. Okay, which is the next table? This one? Oh, up the back. I know, you can go on, you can do it. You need to speak into the microphone, I think.
Generally about the need for maximizing use of resources, so not just about recruiting health resources, but to make sure that you're maximizing the skill sets that all those individuals have, and not just health professions, but also supporting PSWs, family members providing care, that kind of thing, just to maximize what you're able to do in the community. But I did have a couple of questions, and one was related to the use of technology. And do you have any concerns about using iPads and personal computers in terms of confidentiality of information, and does it comply with all Canadian, Ontario, and college regulations? And a second question, you mentioned that 94% of your graduates who are trained in the North and have residencies in the North stay in the North. What percentage of your students who do residencies in the South stay in the South?
Okay, two quick responses to that, and then I know there's enthusiasm to speak from up the back of the room. There are two particularly impressive aspects of Ontario Telemedicine Network which have helped to make it a success. The first is the technological encrypting of the data transfer, because, of course, the privacy confidentiality has been an essential element right from the beginning of North Network, and now Ontario Telemedicine Network. And the other is scheduling. Like, this network wouldn't exist today still if in the early days, when the time was set for the physician to meet with the patient and to do the teleconsultation, one or other wasn't there at each end. And so that's not about technology in the sense of the digital technology. That's about having a well-organized system to have the right people in the right place at the right time. So yeah, anyway, that's covered. And then the question about graduates who go elsewhere for residency, I don't have exact figures, but we are finding that the graduates from NOSM who go elsewhere for residency, many of them are coming back. Particularly, they go and do training in specialties that they can't do residency in Northern Ontario, and they're coming back to practice in Northern Ontario. But we don't have, it's a bit too soon to have solid numbers on that. Okay, up the back. We're not hearing you. I'm not sure why.
Thank you. So my name is Katya Park, and I'm with the Ministry of Health and Long-Term Care, and we had Maria, who was a recent health policy grad, and Kathy from NOSM. And one of the questions that we were talking about is evaluation. So you've talked about a lot of programs, but I'm curious to know what kind of considerations you've had in terms of evaluations for these programs. And I'll let you go, and then the second part would be, for example, developing indicators or even data sharing and how you would get that data and working with different partners in the different communities in terms of evaluation.
Okay, I might give the panel time to think about that question while we see if there are any other tables want to jump in, because I want to make sure we give every table at least a chance to contribute. But the question about evaluation and data sharing, we'll be ready to answer in a minute. Any other tables we haven't heard from? I think over this side we haven't heard anything yet. No one wants to jump up and contribute to the conversation? Yes, go ahead.
Thanks. So I wasn't actually here, so I don't even know the question. But we were quiet, so I figured I would talk. I was actually on the phone doing patient care with a patient who I've sent to the emergency room. So I'm doing telephone medicine, speaking with the emerg doc and the psychiatrist in the last 15 minutes. So I apologize for missing the conversation, but it seems timely. One question I just had that I've noticed, because I've been 10 years in James Bay, Northeast Lynn, with Winnebago Area Health Authority, and I was the director of education for that, and working with NOSM Queens and U of T, as well as now University of Ottawa, having partnership agreements around trying to bring trainees up to the communities. One thing that I've noticed that's very interesting and a little bit odd, just for what it's worth, because again, I don't know the specific question, is just that a number of people seem to be coming disproportionately from Toronto to James Bay, compared to Queens, NOSM, and Ottawa. They all represent, but by far disproportionately, and the number of people who decide to come and train and then decide to actually stay and work in James Bay for a number of years is disproportionately also from Toronto. So the interesting thing for me on that is that the sort of disconnect between the sort of mega urban and the rural remote. And in talking with a lot of my colleagues and friends at U of T, as well as the trainees, what I'm finding is a common denominator is a deep commitment to social justice and restoration and reconciliation, I guess would be the bigger, broader umbrella. And that seems to drive a lot of people, and I think it's an untapped potential. I think it does dovetail with the social advocacy agenda that does exist at NOSM very openly, which is good. I think a lot of other schools need to take it seriously, because what we're seeing is that it really changes people, both in terms of their professional practice, but also their personal lives as well. And I think that's an area that is important as we think about HHR sort of planning going into the future. And I think there's a lot there.
Thank you. So we'll pick up on that point. I don't want to miss the opportunity for webcasting people to contribute to the conversation. Any specific comments or questions from on the web?
It's from Azad Kassam, and they say, I've heard very little about true engagement of Indigenous knowledge in transforming the health system to be culturally safe, and despite significant evidence that culturally informed approaches are far more successful.
Thank you. Let's pick up on those themes, and then there'll be time maybe for one, because I think there's some tables over here have been a bit quiet, but let's pick up on those themes that have been raised, and then one more round, and then we'll do the wrap-up. You want to start?
Sure. In terms of engagement with our Indigenous populations, Don alluded there are two in the Muskoka area, and we have an additional two in the rest of North Simcoe, Muskoka, Lynn. We have an Aboriginal health circle that was established by the communities as well as the providers of Aboriginal health services in our area, and the Lynn has been invited to that table. And that group really represents those communities and the providers, but is gainfully involved in all of the health planning that happens in North Simcoe, Muskoka. The Aboriginal Health Circle also supports many of the other planning tables across North Simcoe Muskoka, our mental health and addictions table, our surgery council, et cetera, so that we have the voices at the table as we do our integrated planning. So we rely heavily on them. They're also around the leadership table. Representatives from Aboriginal Health Circle sit on our leadership council. So on an ongoing basis, we go out to the communities and meet representatives from our board as well as our CEO in partnership with Aboriginal Health Circle to try to better understand the issues that they're wrestling with and how we can work collaboratively to improve the health of the population.
This is a chance to make the point that Sarah Newberry, my counterpart in the Northwest, wanted me to make, which was that she thinks, again, that sometimes a city mouse turns into a country mouse and vice versa, and that she feels we need to increase the pathways or remove the barriers so that U of T, Kingston, Queens, Western can come up to the north as easily as the NOSM students.
I'm going to address data sharing, and data sharing is a nightmare. And if you try to share data across the continuum of care, in today's current structure, it's impossible. And so we're tackling it from the top down. And Lou talked about a single funding envelope. And the likelihood of being able to share information across the continuum of care gets better the larger that single funding envelope. At least that's the premise. And so from a Muskoka point of view, we're starting with privacy and addressing privacy across the continuum of care, identifying the barriers and trying to deal with the barriers. But right now, it's a dog's breakfast, so to speak, in trying to challenge it.
Just building on the point Neil made around the Aboriginal engagement piece, similar very much in the Northwest LHIN, we have an Aboriginal advisory council that we look to very much so, again, looking to empower and engage the local communities on what the solutions are that are best for them, as we have that table to be able to advise us on that through all of our strategies. So just pulling on that theme, and agree very much so with the data sharing pieces. It's a huge challenge and something we need to work through to be able to better care for the patients in a holistic way.
Okay, I'm going to try and make comments about each of the points. I might miss one or two, but I'll try and do that quickly so we can have one more final round. So the issue of engaging with Indigenous, we've heard about with both LHINs inviting Indigenous people to the LHIN table. I think the message earlier this morning was actually joining Indigenous people at their own table and listening to them and being guided by them. That's how we approached it in Northern Ontario with NOSM. Our very first activity actually was a whole of Northern Ontario curriculum workshop. We had over 300 people from across the north who came together and provided guidance and contributed to the initial planning of the Made in Northern Ontario components of the school. And that was in Sault Ste. Marie. And I realised that workshop, if we really were going to understand what the Indigenous people were looking for from their medical school, we needed to actually have a separate Indigenous workshop, which we had at a First Nation just near Kenora a few months later. And so we had over 100 Indigenous people from across Northern Ontario and beyond. And we spent 3 days in small circles and large circles, essentially listening to them and learning from them what they needed from their medical school in Northern Ontario. And we do that, the same thing, about every 3 years. So we call it a community partnership gathering. And we are hosted by a First Nation or Indigenous community, and we report back and seek guidance. So that's how we hold ourselves accountable to the Indigenous people and communities in Northern Ontario. Between those gatherings, we have an Indigenous reference group, which is an advisory committee to me as the dean, and that reference group's role is to hold my feet to the fire, so to speak, in terms of delivering on what Indigenous people expect from their medical school. In addition, we've had 2 Indigenous research gatherings, so separate gatherings that have been just about research, and again, listening and learning and finding common ground in terms of ways of addressing and developing research addressing health issues that are important to people in Indigenous communities. So that's a response to that one. The data sharing, just to reinforce the challenges, the Sioux Lookout Zone or Sioux Lookout Health Authority was mentioned before. The physician group that services those Sioux Lookout Zone First Nations actually owns the medical record. So that means that the nurses and the other health providers don't have access to the medical record. That's on the ground. Okay, so that's a local. On the other hand, at the other end of the spectrum, we are in the process of establishing an ISIS North, so a satellite of the Institute of Clinical and Evaluative Sciences. And the ISIS North will have a sort of a base in Sudbury, but networked right across Northern Ontario. And ISIS has access to a very large range of government-held data, not only in health, but across the activities of government. And in recent years, ISIS has entered into collaboration with the Chiefs of Ontario, so the First Nations, and also the Métis Nation of Ontario. So there is also access to data that way as well. So it's a kind of a mixed picture. The question about evaluation, well, certainly, the principle, and which I think we all hold to, is planning the evaluation, implementing it as you're actually implementing the program. That's certainly what we do at NOSM, and so we've been continuing with tracking and impact research since the school started, and that's how I could quote the data of where our graduates are and what they're doing, and the impact, the economic impact we repeated last year. So in Northern Ontario, there was over $100 million of new economic activity because of NOSM. So, and that's on a budget of $43 million. So more than a 2-for-1 multiplier effect. So that's the kind of evaluation we're doing, as well as research into various aspects of our program. Our medical students have 4 weeks at the end of first year where they're living and learning in Indigenous communities. This is an immersive experience where the students are there to learn from the community about the history, the tradition, the culture, the social and the health issues. I might say we developed that learning from our partners with the Northern Medical Unit in Manitoba, where that sort of opportunity is there for University of Manitoba students for just some of the students. All of our medical students have this immersive cultural experience in first year. And in second year, our students have 2 4-week integrated community experiences in small, remote, rural communities. In third year, they leave Sudbury, they leave Thunder Bay, and they spend the whole of that academic year, 8 months, living and learning in one of 15 large rural or small urban communities. They're living in the community, and they're based in family practice, and they see patients. And so they're actually learning their core clinical medicine from the community family practice perspective, and it's the intense interaction with the patients that I think generates that sense of commitment to responding to individual and community needs, and brings us back to the comment from the first table that we didn't quite pick up about role models and mentors. I think part of the success of NOSM is that the principal role models and mentors for our medical students are rural generalists. And so, my observation, medical students the world over are ambitious high achievers. They want to be the best kind of physician they can be, and if their principal role models and mentors are teaching hospital subspecialists, they want to be teaching hospital subspecialists. And so, in our case, it's a rural generalist. And then, as I've already said, I think the other key contributor in our research supports this is it's the intense interaction with patients that motivates our students to learn. By the end of the third year, our medical students are functioning more like first-year residents. They have a higher level clinical knowledge and skills, confidence and competence compared to the other schools at that stage, which also positions our students to be very successful in matching to residency. And so most years, all of our students at least are matched in the first round of the residency match, the CARMS. On the other hand, 62% of our graduates have chosen family medicine, mostly rural family medicine, as their career direction. So that's almost double the national average going into family medicine. So role models and mentors, and picking up on the point about the focus on social justice. I think it's woven into the fabric of the school, as was said. The opportunity for students and residents from other medical schools to have experience in the north is absolutely there, and NOSM has an extensive program and partnerships with other schools in Ontario and beyond to support students and residents coming. And this, although we in Northern Ontario for our undergraduate program, the MD program, favour applicants from Northern Ontario, as I said, that's based on research evidence that shows that the strongest factor associated with going into rural practice after education and training is a rural upbringing. That's if you're going to put your money, if you're going to bet, that's where you want to put your money. It's also true that most rural doctors grew up in the city. And so I regularly get this kind of comment. And of course, that's because there are a lot more medical students in the city, including in Toronto, more medical students than a couple of other medical schools in Ontario put together. So we in Northern Ontario do see this as an important opportunity. And there are some communities that the word of mouth from U of T students is positive about that community. And so more U of T students go to that community, and actually they've been successful in recruiting U of T graduates to those communities in the north. So that factor is there as well. I think that's covered the comments we've had so far. I'm just wondering if in this sort of part of the room, any of the tables want to say something before I give each of the panel members the opportunity to make closing remarks. Okay, it's closing remarks time. I was thinking we might start at the other end and work towards me. Are you okay with that?
Sure.
Away you go.
Closing remarks in terms of capacity and development, again, go back to the complexity of, and yet the simplicity of partnership, and the need for the development of relationships, the development of trust to be able to move forward with any partnership, regardless of culture.
I think the future holds building communities of care in each of our communities, sometimes clustering them. So that'll be good for patients and good for the retention and recruitment of healthcare professionals.
I'm just going to steal the theme of partnership. I think it's that important to say that we have a lot of challenges out there. We have some great ideas, but we need to partner and empower the communities to help us come up with these solutions so that they're sustainable based on what the communities need.
I want to just close by saying that with the work that was done with the Mass Planning Council, we are decided or plan to make a fundamental shift from a kind of a hospital-centric way of doing business to community-centric. And that is a huge shift within our community. We're trying to move a number of things out of the emerge ward that shouldn't be there. And to be able to do that, we need to better support primary care. So it's a big challenge for everyone to get to the point that we need to get to. But it's what we envision that is best for our community.
Okay, so some closing remarks from me. First, picking up on the theme of the health workforce and the importance of having a fit-for-purpose health workforce. That does mean having a pathway, preparing, choosing students and learners who have the inclination and the interest and the willingness to, and then providing the learning in context. I want to pick up on the theme that I mentioned in my introductory remarks about the three-legged stool and the importance of strengthening the three legs. Sometimes communities are in a particular sort of situation, you might say in a rut, where there's a particular arrangement. Physicians, other healthcare providers are doing things the way they have been doing things for a long time, and that works well for them. But Paul's already talked about the difference between the way that he learned to and I guess continues to practice and recent graduates. So recent graduates are not necessarily attracted to running a small business. They prefer to be providing healthcare, being part of a team, as mentioned as well. It requires the hospital and health service actually to see the value of the partnerships, the collaboration, the working together, and it requires the community to step up and to be actively involved to help ensure a sustainable service. And sometimes what's needed is actually some help from outside. in Queensland, Australia, the Queensland Health has developed what they call Queensland Country Practice, which is a service that works with communities. It's a service and workforce development team that goes into a community and actually then connects with all of those players that I've mentioned, the physicians and other healthcare providers, the hospital health service, other agencies in the community, and the community at large, and to works with them to redesign maybe the service model to make it sustainable and effective in terms of addressing the health needs of that community, and make it attractive to recent graduates, physicians and other members of the health workforce to want to be part of providing that health service. We've been talking with the Ministry of Health and Long-Term Care, and I believe we're likely to get funding to be able to learn from, have a knowledge and skill transfer from Queensland, and to be able to offer a similar service and workforce design team model in Northern Ontario to work with communities. So that's something we're working on. And we're also seeing that with the partnership theme, that there needs to be collaboration with all of the players and to really look at, explore, examine all of the issues in terms of supply and sustainability, retention, recruitment of the health workforce. And so we're working towards holding a health workforce summit, most likely in Thunder Bay later this year. The partnership theme for NOSM, as I mentioned already, we have many partnerships, and we have formal partnerships with the LHINs, all three LHINs represented on this panel, but particularly the Northwest and the Northeast, with the hospital and health services I've mentioned, and with Health Force Ontario, marketing and recruitment agency, whose role for the province is to assist with recruitment and retention of health workforce, and we've been encouraging them to help us in the north to be able to deliver what's needed. And we're in the process of formalising a collaboration with Ontario Hospital Association. So, and we heard this morning about the great contribution that OHA can make. So that's something to be aware of and looking forward to. But I want to come back to the partnership theme and in a way close where I began, with the focus on active community participation. And I want to mention the partnership pentagram. So the notion of social accountability, that is for us as an education institution, that all of our activities, education, research and service, are directed towards addressing the priority health concerns of the community, the region that we have the mandate to serve. That's the definition of social accountability from the World Health Organization. The next step is, well, how do you decide the priority health concerns? And that's where the partnership pentagram comes into play. It was originally called the partnership pentagon, but then it was realized the term pentagon's been used for something else that maybe isn't quite the right sort of message. So it's the partnership pentagram, and as we've heard, it's in one form or another. It's not uncommon for health service, health system managers to contribute to planning, for the healthcare providers to contribute to planning, to the health service institutions to contribute to planning, to the academic institutions. So that's four if you're counting. But the fifth partner often is left out, and that's the communities. And so back to what really is a key element in success in developing and maintaining sustainable health services in remote, rural, Indigenous communities is active community participation. And in the centre of the pentagram, if you've got a pentagram in your mind, is the health needs of the population. And so you have to actually ask the people and go to the table and listen and be guided and make an effort really to ensure that those voices that often aren't heard, and those that are we've certainly talked about Indigenous voices a lot today, but there are others as well, to ensure that their voices are there as well. So active community participation is a key, and to have then design a service that's about the health needs of the population. And if you start with there and work from there, rather than starting in the middle, like with the healthcare providers or the health service agencies or the health system, then it looks very different. And I think that's the way of the future, is is starting with the health needs of the population and developing models of care services that are designed and developed with a focus on addressing the health needs, the priority health concerns of the population that you're serving. That brings us to the end of this panel discussion. On your behalf, I'd like to thank all of the members of the panel and have a round of applause for the panel. Thank you, panel.